Can you hear me? Is my audio okay?
All right, good morning, everyone. I'm going to get us just started just a little bit early here. Just a few housekeeping things really quick. Want to make sure that, again, you know that you're in the Hot Topic session. If you need any CEUs for this session, I did launch a poll before, and you can see that in the little chat box on the side or the feed. If you need any of those, please fill those out. And we also would like you to complete the evaluation that we will launch at the end. CEU certificates will be emailed to you again after the conference. And if you have any questions about CEUs, I would direct you to Sonia Summers in our office, and she will help get you sorted out. Today, you are in the Hot Topics track. We are pleased to welcome Dr. William Mills. Before we do get started, though, this session is sponsored by our friends at I Am Boundless, and I think that they may have a special message. I'm not sure. Chris, are you on? I'm going to go ahead and turn off my feed. And Chris, if you're on, I know we are just a smidge early. And okay, I'm back on. Chris, Wolf, are you on yet? I don't know if maybe you having some trouble. Lots of noise. Yes. That should disappear as soon as I hop off.
So can you hear me now?
Okay, I don't know if Chris is here, but this session is brought to you by our friends at I Am Boundless. Perfect, looks like everybody can hear. I will just go ahead and turn it over to Dr. Mills then. Thank you all for joining us today. Please, if you have any questions or comments, use the chat box.
Good morning. Can you hear me okay? Let's see if we can help with that echo here. Is that any better? All right. Well, we'll go ahead and get started. Is everyone able to see my screen as well? All right. Perhaps, and I'm not sure, Melissa, if we're able to, but sometimes having others mute themselves could be helpful to avoid some of the echo. I've got mine, I think, moderated okay, but there still seems to be a bit of an echo. All right, well, please let me know if the echo becomes distracting and we can try to figure that out. Well, thank you very much for making some time to talk about what I believe is an exciting and very timely topic this morning. Thanks very much to Oprah for allowing us to speak about leaning into value-based outcome measures in the field of intellectual and developmental disability. And, really, hopefully, over the next 40 minutes or so, we will, kind of develop an understanding as to why value-based outcome measures are important, what some of the main value-based outcome measures that we are starting to study and believe are very relevant to the field of IDD, and then kind of apply the outcome measures to kind of our current experience with the COVID-19 pandemic that hopefully will be instructive as well. So I'm going to go ahead to full screen mode so everybody can see hopefully a bit better. So first, really the question is, why do we need value-based care? This has been a kind of a question or a topic that has really permeated a lot of different fields in healthcare over about the last 10 to 12 years or so. And, it's really because healthcare spending overall in our country is very highly concentrated among a small sliver of the population. So really, in fact, about only 1% of people expend around 23% of the total healthcare spend in the United States, and about 5% expend around 50% of the entire healthcare budget in the country. And when you look at it in terms of actual dollar amounts that are spent within each year, I think the numbers become even more staggering. So that top 1% is costing the system around $100,000 per patient per year, and that top 5% over $40,000 per patient per year. So really you can see that there's a striking amount of resource use that's really allocated to a small percentage of the population, whereas the entire kind of bottom 50% is really hardly expending any healthcare dollars whatsoever. So 2 outcomes measures that we'll be talking about during the course of this presentation and that we've really begun to adopt within our BrightSpring organization are hospitalization rate. So very simply, how often a given person or a given population is hospitalized during the course of a year. And we'll be talking a bit more about how to actually calculate it, but very simply, you need to track the number of hospital admissions that a given panel of patients or cohort uses, and then you also need to know how many months that your organization's been managing that population. And then with those 2 data points, you can easily calculate the hospitalization rate per 1,000 people per year. The other outcome measure that we found to be incredibly useful is called days spent at home. And we'll be talking a bit more about kind of the genesis of this outcome measure and why we believe that it's very impactful to the field of IDD. But very, kind of simply, it's the total number of days that are in a calendar year, so 365, and then you subtract out the days that a given individual spends in non-community-based settings, so in hospitals, nursing homes, other kind of institutional settings. So, very simply, it's, the days within the community minus the days kind of outside the community in hospitals and other institutional settings. Finally, there's a measure called inpatient days per 1,000 that is used a lot by payers and population health kind of studies, and that's basically the number of inpatient days. So hospital, nursing home, LTAC, other inpatient facilities that a given cohort is using over the course of a year. But we're really going to focus for the point of this presentation on the hospitalization rate and days spent at home because they're pretty straightforward metrics. So just first, some kind of rationale and benchmarking. Reporting hospitalization rates really enables organizations to, number one, find out, how good of a job that we're doing in empowering, enabling individuals or patients to stay in the community and out of high-cost hospital settings. But it also enables us to hone in on avoidable hospitalizations, which clearly, anybody who's had a client, had a patient, had a family member, had a loved one, be in the hospital once or twice or three times within a given period, it's a place that, for the vast majority of reasons, we prefer to avoid unless there's something that really is unavoidable, like an intensive care unit stay, a surgery, or certain other conditions. But most, as we call them, ambulatory sensitive conditions, can and should be treated outside of hospitals when possible. So as far as benchmark data, most of the benchmark data for hospitalization rates really comes from the Medicare program. There's much less kind of umbrella data for Medicaid, but in the Medicare program, as you might expect, hospitalization rate increases with age. So the average rate within the Medicare program is around 250 or so hospital admissions per 1,000 Medicare beneficiaries per year. And that number then increases. So those who are 85 and older are hospitalized at about twice the rate of the general Medicare population. It goes up even higher if you look at kind of the 90-year-olds and higher age strata. And then other programs that have really been engineered in part to help reduce acute care use, such as the PACE program, which some of you may have heard of, otherwise known as the Program for All-Inclusive Care of the Elderly, which effectively provides community-based supports for nursing home eligible residents that provide a lot of access to on-site healthcare programs, services, rehabilitation, et cetera, has been able to report rates of about 540 admissions per 1,000 per year. Dually eligible beneficiaries, so those who have Medicare and Medicaid, have rates that are close to 1,000 admissions per 1,000 people per year, which effectively means that on average, just about every person is being hospitalized once during a calendar year, which is obviously pretty taxing on them, and obviously also difficult for the system. And then there's been a lot of value-based care initiatives over the last several years within accountable care organizations and other Medicare and Medicaid programs that have looked at figuring out different ways to enable care outside the hospital, and some of these have had some pretty good success in reducing rates in high-cost beneficiaries, such as some of the home-based primary care accountable care organizations that we'll touch on a bit more in a few moments. So days spent at home, I think is a really nice metric for a few reasons. Number one, because you can explain it to anybody. You can explain it to somebody in an elevator within a matter of minutes. You can explain it to policymakers. You can explain it to really just about anybody, right? That again, it's how many days are in a year, subtracted out by how many days that individual's in a hospital or nursing home, and you're left with the days spent at home in a year. This measure was really started because it came to be pretty obvious that through doing surveys both in the UK and in the US, that when asked, people kind of towards the end of life had kind of as their number one answer when asked, what do you want out of the course of the rest of your days? Their number one answer, 86% of the time, was to spend more time at home and less time in hospitals and nursing homes. So, in that respect, it's very much a person-centered outcome measure, which is obviously, terrific for us to be able to incorporate, people's wishes into the metrics that we're developing. So a lot of this work initially was done by Adam Groff and some folks at Dartmouth, and they looked at it mainly in the last 6 months of life, and they found that, as shown on the map here at the bottom of the slide, the success or the lack of success that we as a country are having in enabling people to spend more time at home is extremely variable around the country. So, really the various kind of color variegations here just show that in some areas, we're only enabling people to spend about 120 out of 180 out of a 6-month period, days at home, kind of up to 146. And maybe no surprise, but the amount of hospital utilization is really directly proportionate to where the person lives. And so if there's more healthcare, more hospitals in a given geography, those people tend to be hospitalized more often and spend less days at home in the community. So I think it really paints an interesting picture about resource use and appropriateness of resource use in our country kind of at large. So we've kind of been one of the individuals, the organizations who have tried to kind of use days at home outside the kind of Medicare and end-of-life definition and apply it to a variety of other populations as a person-centered metric. So we've been studying this now within our IDD population for about the last 2 years or so, and have found that our residential waiver population spends about 360 on average out of 365 days at home per year. And then we've looked at some other populations that we provide care and services to through our various service lines, and our advanced elderly Medicare patients, as an example, are spending about 358 days at home and outside of hospitals in senior living. So really the mantra I think that is emerging is that if you can help enable a day at home for a complex patient, that's typically a good day for the patient, for the family, and for the payer. And so really driving this number as high as possible can truly be a unifying outcome measure for community-focused healthcare organizations. And we've adopted this at BrightSpring as one of our main unifying outcome measures, despite the fact that we have about 11 different business lines that are all kind of trying to help enable people to succeed at home in the community. So some enablers that we'll talk more about, as we go as well of days spent at home are things like community-based access to care, care management, medication management, and care coordination. So, really thinking about these 4 pillars and then how to apply them to the IDD population in particular is potentially one of the most significant innovation opportunities within IDD. So, really kind of as a mission statement, we're thinking about it as, we are trying to enable individuals to stay in the community and out of inpatient settings more days per year. And then we try to align a lot of our operational efforts to do just that. So we've published a couple research articles on this space, and I'm just going to kind of highlight a couple of the things that we've learned during this. First, there's been an increased use has published research that shows really which standards can and should be used for people with IDD. So we sought to build an algorithm that can determine the annual hospitalization rate and then also the days spent at home for our IDD individuals enrolled in residential waiver and to try to put these forth as potential value-based outcome measures for people with IDD. So we looked at a 1-year study period, and this was a cohort out of our about 11,500 individuals with IDD that were in our community living waiver program. And we tracked each individual's whereabouts every day using a tracking database. And very simply, it may sound very commonsensical to all of us, but the first thing one needs to do is to know where your resident or your patient or your individual is each day, which is not always trivial when people may be out in the community and and using care and services. So that was entered into Interactant, which some of you may also be using. And then we performed a review of that database that looked at length of stay, and it manages our census. We then calculated the total managed days of an individual that we served simply by the total number of days that individual is being served by us minus the days that they were on leave or otherwise outside our auspices of care and service. Hospitalization rate was then calculated as mentioned before, so the number of admissions divided by the managed months, and then we normalized that per 1,000 patients, and we annualized that over the year. And then we calculated the other measures that I mentioned as well, inpatient days per 1,000 and days spent at home during the course of that year. And here are our results. First, during that 1 year period, we served about 2,400 individuals in community waiver programs across 12 states. As I mentioned, you need to figure out how many days in total and then how many months that represents overall. So this was around 750,000 managed days. The average age was about 46. Most of these individuals also had significant medical diagnoses in addition. During the course of that year, 20% of that cohort had at least one hospitalization. One thing that we found to be quite striking and also, pretty instructive for go forward, we'll talk more about in a bit, but the length of stay in the hospital for these hospitalizations was just extremely variable. So, we had hospitalizations from 1 day all the way up to many tens of days, even up to a couple hundred days in 1 or 2 cases, which was just an incredibly long time for any person to be in the hospital. When thinking about a rate, we calculated that our hospitalization rate in this residential waiver program was 240 hospitalizations per 1,000 managed patients per year. And then the inpatient days that I mentioned, about 5,000 inpatient days per 1,000. And what we found to be interesting about this is it kind of like that first slide that I showed at the outset, showing that a very small percentage of the overall population of the United States uses a lion's share of the services. Kind of the same thing here, that this inpatient days number was really driven by a small subset of people. So 29 individuals out of this cohort, so 1% or so, had lengths of stay greater than 100 days. And these, by and large, were very long stays in behavioral health institutions, and so obviously a potential opportunity to provide more resources to individuals in the community. And then that days spent at home number, I think I may have mentioned this before, but kind of across our population, it's borne out to be about 360 out of 365 days a year are being spent at home. Said another way, 98.5% of time that individuals with IDD in our waiver programs are under our care and support, they're spending in the community and outside of these settings. We also found that there was fairly significant variation geographically, kind of akin to that map that I showed at the outset in the Medicare population. So certainly some variance by state, which we're helping to then inform our operators with, so that we can kind of figure out local tactics to help drive success and to drive that days spent at home number as high as possible, using both existing and new innovation and resources in given markets and given states. So the way we've kind of encapsulated this particular study is, first, we believe that hospitalization rate and days spent at home may be 2 important emerging value-based outcome measures within the field of IDD. We've established some benchmark rates. Our hospitalization rate of 240, our days spent at home of 360. To our knowledge, there really hasn't been reported rates of either of these in the IDD space in the peer-reviewed literature to date. In the United States, there was one study in Canada that we're familiar with. And the other kind of main take-home for us, and I imagine for other organizations, has been that while most individuals, so 80% plus, were not hospitalized during the given year, a very small subset had very long lengths of stay that really drove a lot of that inpatient utilization, and many of those were around severe and refractory behaviors that could not well be managed in the community. So, we're really looking to this as one of the emerging studies of new models to support the care for people with IDD, and specifically have begun augmenting our outpatient behavioral health supports so that we can really, kind of get ahead of some of these emerging needs and hopefully head off some of the, hospitalizations without compromising care. And so future studies should really evaluate, whether or not matching some of these enhanced community-based resources can help decrease hospitalization rates and days spent as an inpatient. And then, kind of specific tactics. We have some of these studies ongoing at present, but, looking at enablers of reducing hospitalization rates. So things like improving or enhancing access to care for individuals in the community, using nurse-led care management programs that can risk stratify based on an in-person home assessment of individuals with IDD. We have a study that we recently completed that is expected to be published in the next couple of months on that. And then med management, such an integral part of an individual's overall care plan that they, have a thoughtful approach to their meds. So doing what we can to reduce polypharmacy, trying to reduce that med list that may be 12 or 15 meds down to something that has less opportunity for non-adherence and for drug interactions to streamline their med regimen. And then, as I mentioned, to drive adherence, which is obviously key. And then care coordination. So trying to, couple the identified needs that an individual has with a coordinated care effort to try to be very multifactorial in addressing complex care needs. So, we think that these are simple metrics that, virtually any organization can measure. And, we're hopeful that they can lead to conversations that can help really promote provisioning of resources, so most appropriate resources going to the people most in need. And then also as managed care becomes more active with Medicaid and state programs, that these may become an opportunity for conversations about value-based care initiatives within managed care as well. So we really see it as an innovation opportunity for the field of IDD. So one of the things that we've done as an organization is we have kind of the caveat to those providers on our call, on our meeting today, that don't have kind of as many service lines as a large organization like us. But anybody can develop outcome measures and start to figure out ways to track them. And we'll kind of come back to that a little bit later. But we've taken the approach where we're trying to get each one of our service lines to feed in various outcome measures so that we can kind of use a dashboard driven view of how we're thinking about how we're doing in providing for the needs of whether it's individuals with IDD, whether it's recipients of our pharmacy services, whether it's home health and hospice patients, really whoever it is. So we've really taken this opportunity to say, well, we're going to try to drive performance and success using value-based outcome measures, but then we're also going to kind of make them as transparent as possible and as accessible as possible and report on them, with a certain frequency. So we have a team of kind of multidisciplinary or cross-disciplinary rather stakeholders who are really all contributing to this project. And there's a lot of neat tools out there today that do enable data reporting and data visualization in a way that you can effectively show outcomes on a screen in a conference room or virtually as we are today, and to be able to kind of think about how to improve given metrics. So we think it's an exciting project, and specifically in the field of IDD. So we call our IDD business community living. So that's the CL on our dashboard here. And effectively what we've started to do is to take the data that I showed you and some of the published data and the research articles, and then to feed those metrics into our dashboard so that we can have informed conversations about how we're doing with our inpatient days in our ICF versus in our residential waiver, how we're helping to address, like if we've had a given increase in hospitalization rate in a given state or a given market, then we can, kind of plan to solve how to help resource that and hopefully, address that in the upcoming, weeks and months. So really, we think that an innovation opportunity is to enable individuals with IDD to stay in the community and out of inpatient settings more days per year. And to be able to get there, right, you need the data first. And that's really what I would encourage everyone to think about is you don't necessarily need to have a fancy dashboard or a fancy, technology, build, but just kind of figuring out how you might be able to get at measuring hospitalization rate, knowing where your residents or individuals are is a key first step. And then, some interesting things, just I think highlighting the opportunity here is because the value-based outcome measure discussion in the IDD space really is very nascent. It's in today's day and age where everybody searches everything on Google, you can kind of see how published innovation then pulls in as, kind of thought leadership in the search engines like Google. So, if you type in IDD hospitalization rate into Google, the study that we wrote a couple of months ago, or maybe 4 months ago now, comes up as the first hit there and comes up with a frame of reference. So, just a lot of opportunity for, I think, other studies and publications to drive, knowledge so that we can, help to advocate for people with IDD as best we can. All right, so I'm going to shift gears a little bit, but really the point of this next, kind of period of this presentation is to show how some of these same value-based outcome measures can be instrumental in helping organizations assess how we're doing with our COVID-19 response. So, first, I'll just say, probably state the obvious. This has been obviously a really challenging year for all of us for a lot of reasons. I would say that probably no group of people has been more severely affected by COVID-19 than those who live and work in congregate care settings. So settings where multiple individuals live, whether that's in group homes, whether that's in senior living, whether that's in nursing homes, whether that's in ICFs. We've seen that, kind of going back to the springtime, that some of the worst outbreaks that we've had in the United States have been, first on the West Coast and then on the East Coast, and then in other areas too. But well-intended nursing home employees who inadvertently, accidentally, brought the virus in, and then it really unfortunately ran pretty rampant in some of these settings. So really the one of the worst statistics that I've seen in this last nearly year now since COVID is that although long-term care facilities as a total of total cases in the United States only make up 8% of cases, those same cases have made up 41% of the total deaths, just really illustrating what a disproportionately terrible toll that those living in congregate care settings have experienced. So, this is a statistic that I think we can all agree is pretty awful, and we need to figure out how to improve on that. One of the things that we've done is to take a look at some of these outcome measures that I outlaid here, days spent at home being one, and kind of then map it out over the course of the last year, and seeing how these rates or measures may be influenced by what's going on externally. And obviously the main thing going on externally now is the pandemic. But as I mentioned before, kind of in last summer, so summer of 19, we were hovering at around a 98% days spent at home rate, even a bit higher than that, closer to 99. And then kind of during last flu season, so October-ish, we started seeing this, what we think is probably a seasonal trend. To our knowledge, it's just that people really, organizations really haven't reported days at home on a seasonal basis before. But we think this is probably going to show up to be this way every year, where you have individuals who have flu and other infectious illnesses, pneumonias, et cetera, who end up hospitalized and then are spending fewer days at home during the wintertime. But then maybe curiously, after the first case of COVID-19 was reported in the United States, so in late January 2020, we maybe paradoxically didn't see the rate of days spent at home decrease. We saw it increase, right? And partly maybe because there were, by early March, there were stay-at-home orders, and frankly, people were worried to go out and get medical care, and many people still are worried. But so we actually saw that the days spent at home percentage increased to back over 98% during the early days of the pandemic, and we're still following this trend out, kind of as we go. And this was published recently in a study. So just to kind of encapsulate some of the steps that we've taken, and then we'll kind of come back to some more of the data. But we've been monitoring, managing the situation on COVID-19 daily since February of 2020. We had really a multidisciplinary group help create and align on new policies, protocols, trainings, communications all across our operations, which span all 50 states. And then really it was about just making sure that people really understood how to do appropriate infection control. And just making sure we learned from some of those examples where we had the well-intended caregiver or nurse in long-term care facilities who came in and introduced the virus. So we limited and then stopped travel entirely, and really shifted to remote work, such as this web meeting that we're having today. We implemented guidelines around meetings, so for kind of mandatory orientations or new hires. Obviously, we figured out the distancing and all the safety measures needed to still be able to appropriately have some in-person meetings as well. And then we've been very fortunate, in fact, to have a dedicated team who's really helped to procure the scarce PPE, the masks, the gloves, the gowns, et cetera, that everybody has needed. And they've done a really good job helping to ensure that we had adequate supply. Something I'll come back to, but I did it myself this morning. I've done it just about every day maybe outside Sunday or something. But that we report to work is everybody takes their temperature. We do visitor screenings, answer symptom questionnaires, and then report on it in a system that we created so that we can track, if people have had a temperature or any affirmative symptom response, and then that goes up to that employee's manager. We've developed some new tracking tools that I'll show you in a moment, so we can really visualize where we've had some pandemic activity. And then really just managing through the employee contacts, client-patient at-risk situations, and sick leave and pay. And a big part of my personal effort as the head of medical affairs for our organization has been to do triage for people who've had either contacts or concerns about, a family member, a spouse, an employee, somebody at the workplace who may have had an exposure or a symptom. And it's been, I think, a lot of, at the beginning, there was a lot of angst. I think that a lot of that now has become more streamlined, and I think people generally are getting more into the cadence of just knowing what a close contact is, knowing what to do to protect ourselves, all those type of things. IT has been a big enabler of helping us build some tools that we'll show you in a moment. And then we've had really a great effort by our nursing team. It's really our quality team of nurses who then have really pivoted over the last several months to help triage and lead some of the support for the local operations in identifying and helping support given cases. And then we've done a lot of preparedness drills, which obviously are important. Here's a glimpse of one of the tracking tools that we use on a daily basis, multiple times a day, in fact, to kind of track with an organization that's large, and has operations all around the country. We need to be able to visualize, kind of where we have cases, how many, which service lines, when, both for our own triage and safety and quality, but then also for, external reporting to health departments and, and all the appropriate, steps there as well. So effectively, the given field-based employee can enter in a case into a cloud-based database that then will auto-trigger both the nursing team and, if an employee, also the human resources team to help support that given individual as they, as they deal with either an exposure or symptom, et cetera. And so this has worked quite well. It also allows us to report out data and then also to distribute PPE as needed. If we see that, we're having a given, spike or activity in a given area, we can then, deploy PPE, appropriately to that area. We've also developed a lot of resources. So as many of you certainly have, most all of us have learned probably more than we ever wanted to know about COVID-19 over the last few months, and maybe viruses and infectious disease, more generally beyond that. So we've had a group of folks who've been very busy creating content and resources around infection control, around protocols, policies, videos, educational materials, and we started out by just putting these on our company intranet, internal internet, and then we were actually asked by some external stakeholders to just put them on our external website, our main website, and we did that, I think, back in April. So all of our kind of learnings are publicly available, and for anybody who wants to use them or to learn from anything that could be helpful. Now, the other thing that's been really important is that any of you who've either put on yourself or have helped others put on full personal protective equipment or PPE, it takes a little practice. And so we've had a very busy infection control kind of education series that's been ongoing ever since February. We've had nurses doing these. Initially, they were doing them twice a day, and then after, I don't know, maybe 3 months, they went down to once a day. And then now I think it's like twice a week. But it's kind of keeping that cadence that people can be educated, reminded, and trained appropriately on infection control is probably the number one thing that has enabled us to keep the pandemic relatively at bay. So during the last few months, we thought it important to also then, with some of the best practices, to report them out in peer-reviewed research journals. And So I'll kind of talk just a bit about each one of these, and then give some more detail on the IDD study that we did in a moment. But so we first reported on supporting individuals with IDD during the first 100 days of the pandemic. This was back in May, June, when people were just starting to kind of see how people were faring, and we had an early data set. So we thought it important to get that data out there so that we can hopefully help others who are dealing with the same thing, both within the IDD field and more broadly. And fortunately, that article has been really well received. It's actually tracked like in the 95th percentile of all the articles that are tracked by a research site. And it's always heartening to get good feedback. So professors and others from different places were saying things like, this shows how vulnerable people in care homes can and should be protected during COVID-19. So it was heartening to see a lot of that. And then we also kind of used that same lens to help prepare some of our other service lines. So home health care, personal home care. We've published an article over there kind of looking at how our caregivers going into individuals' homes or into senior living have been prepared to help them combat it as well, and to minimize exposure risk from our own staff. Primary care, we have a primary care and assisted living business as well, and we really partnered strongly there with senior living, mainly to help keep virus out and to help keep cases very low. And then we have a long-term care pharmacy called Pharmerica that may be familiar to some of you. And our pharmacists there were able to do a really good job in partnering with their facilities, both IDD facilities, SNFs, senior living, et cetera, to help the individual communities prepare optimally from a pharmacy approach. And then we also saw some interesting trends. You may remember this whole buzz about one of these drugs, hydroxychloroquine, back in March, partly because the president was touting it as something that people should consider using. And so, we tracked through our pharmacy kind of how the prescription numbers for that drug, changed in count during that period. And, after the FDA cleared the drug and after the president was talking about it, the numbers, spiked way up. And then you may remember that some period of time afterwards, I believe it was about 2 months, maybe a little bit less, the FDA then pulled that authorization for hydroxychloroquine and COVID because there was some concern about safety, and then the prescribing numbers went way down. So trying to provide some evidence and some data behind some of the things that we've seen and heard about over the last few months. One of the most important things I think that any organization can do is just to have a regular daily cadence, as I talked about a couple minutes ago, about just ensuring that we're all safe. Obviously not one of us wants to intentionally harm any other individual or patient, right? That's why we're all in this field. But the cautionary note is that you may be unintentionally harming somebody if you're not, kind of being very diligent about screening. So just to make it easy, we built an app that everybody has kind of on their calendar at 8 o'clock in the morning, to do a self-screen and record their temperature and answer a symptom questionnaire, push submit. It literally takes, 10 seconds, maybe plus the 10 or 20 seconds that it takes to take your temperature. And then that's really helped us, to streamline our safety approach. And then any positive symptom screen is then reported off to the supervisor. So you've probably all seen curves, kind of case curves in all over the media and other places. So we've tried to carefully collect each new case within our organization, both on the employee and on the patient client side, and We trend this on a weekly basis out. And the goal is obviously to keep the curve as blunt, as flat as possible. And really the punchline is we've been fortunate to since just the 26th, so as of 2 days ago, the U.S. population is around 2.6% of the population has had a positive COVID case, and we've been able to keep our rates around 1%, so about 62% lower than the U.S. general population, which is obviously paramount when you're providing care for the vulnerable. So on the IDD study that I mentioned before, that kind of approach that we talked about, the tactics that have led to low infection and hospitalization rates, a couple of interesting observations. Number one, out of 66 positive COVID-19 positive clients in our IDD business in that first 100 days, 15 were hospitalized. So about a 22% hospitalization rate in that first 100 days. And we did unfortunately have three people who died of the illness. Really the interesting trends that we noticed in looking at this data were that those who were hospitalized, and then those especially who unfortunately succumbed to the illness, were older than those who were not hospitalized with COVID-19, and they also had a significant number of chronic medical conditions, a significantly higher number of chronic medical conditions than those who were not hospitalized. And so, this was data from about 11,500 people and 2,400 homes around the country. We just report as well on how we place people in quarantine if they were exhibiting symptoms, which certainly, as you all know, is not necessarily simple or straightforward, depending on the nature of one's diagnosis, et cetera. And then really the main thing that we try to do is to contain cases where there was a positive case in a home, so that there wasn't a second case in a home, so we didn't have a cluster or an outbreak. And you can see out of those 30 cases that we had initially, 15 homes had single cases, then 15 had more than one case. So really trying to figure out best practice ways to isolate those who are sick and keep them from getting others sick as well. So really in summary, focusing on implementing best practices in infection control, on visitor management, employee screening, and then reporting and triage protocols, we think is a key to optimally supporting clients, patients, employees, families, and the communities. And so far, it's worked pretty well. With that overall infection rate that we've had of about 1%, as I mentioned, about 62% lower than the U.S. And the work has informed some of the policy documents from the World Health Organization. This policy brief entitled "Preventing and Managing COVID-19 Across Long-Term Care" referenced the work that we did, and it's since been translated into 2 or 3 additional languages. So it's heartening that when you're trying to get people doing their best to provide a safe environment, can get some notice, and then through that help others as well. We also received, as maybe others have as well, allocation of the rapid antigen tests from Abbott Labs, and we're starting to refine ways to use those as well to augment our daily screening approach. And we've also, our pharmacy officer has a seat on the Department of Defense's Operation Warp Speed, which is the vaccine project. And so we're hopeful that the IDD space in general will get similar priority, if you will, to that of the nursing home industry, which has kind of been that top priority. But we're heavily advocating that IDD in our space gets that preference as well, as certainly they should for access to a safe and effective vaccine. So in conclusion, congregate care settings, including group homes, ICFs that support people with IDD, have been really hard hit or severely affected by COVID-19. But just by doing the basics, by doing the basic infection control, watching out, for visitors who may be ill, employee screening, reporting, it can work and can keep the spread low. And then really organizations that provide services to individuals with IDD, have a great opportunity to deliver value. But the thing that I think we all need to try to do is to try to objectify that a bit more through data, so that we can demonstrate, through metrics such as hospitalization rate, days spent at home, that there's really just a great amount of value that we can provide when we're trying our best here to support individuals. So effectively, if we keep hospitalization rates low and days spent at home high, this can really help us achieve goals of families, residents, and then ultimately the healthcare system and payers as well. So, I really think that COVID-19 has helped to shine a light on how, these value-based outcome measures can illustrate an IDD provider's value. And, I think that this illustration of value will persist long after COVID-19 is over, which we all hope is sooner than later, of course. So thank you all very much. I will get out of the slideshow now. And I'm not sure if we have an official way to receive questions or not. I don't know, Melissa, if you're on, but otherwise I'll just wait patiently. All right, well, thank you very much, and I hope you all have a good day. I appreciated being included in this session. Thank you.